Okay, so let's transition. Let's turn attention to ALK translocated disease. And like EGFR mutants, we've had a change in the standard of care with crizotinib. And Dr. Stinchcombe, if you could walk us through the first and second line trials that really defined a new standard in the ALK translocated population.
So the first line trial was recently published, and it compared patients with ALK rearranged lung cancer to crizotinib versus a platinum pemetrexed. And this patients assigned to the ALK inhibitor crizotinib had a much higher response rate, as well as a longer progression-free survival. And for me, this sort of confirmed what I was already doing in my practice. It was sort of more of a reassurance. And I think that that's from patients in my clinic of ALK rearrangement, I initiate therapy with crizotinib at this point. I think the important thing to also not forget in this trial is the patients who got the platinum pemetrexed still had a response rate of about 45% and progression-free survival of 7 months. I've also used that to tie patients over when I'm looking for a trial, or maybe they've progressed on the 2 available ALK inhibitors. And I think we should be hesitant to just forego chemotherapy. It should be a second choice, but it should not be thrown away.
And the same thing was demonstrated in the second line trial against single agent therapy. And I think your point is that we saw in the second line trial that the response in PFS to pemetrexed on the control arm was superior to docetaxel. So pemetrexed seems to be a bit more active of a cytotoxic agent. And we saw that in the first line trial, where I think the PFS on the control arm median was 7.4 months or something in that issue, which we typically don't see with a doublet in that particular setting. Heather, what's known about, we spent a lot of time talking about mechanisms of resistance with the EGFR population. What about this population?
So it's not as clean of a story. We don't have one dominant mutation. When we're dealing with ALK, obviously it's a translocation as opposed to single mutations, and there can be different partners. And that certainly plays some role, but not enough that we can really tease it out and say, well, EML4 is going to do this and these other partners are going to have this effect. When resistance to crizotinib develops, we know that it tends to be a secondary mutation within ALK itself. And there is a classic kind of gatekeeper mutation, but it's not the 50 to 60%, it's a much smaller percentage. And there are multiple other mutations that have been identified as well. And what's interesting is that there are multiple ALK inhibitors in development. So we have crizotinib, and in the past year we also have ceritinib now approved for patients who have previously done well on crizotinib. And what's interesting about ceritinib is that it works quite well whether or not a patient has previously had crizotinib. The response rates are a little bit higher if they have not had crizotinib, but they're still close to 60% in the 50s, even if they have. The progression-free survival is longer if they've never had crizotinib, but it's still pretty good if they had. And when one goes into detail, it becomes apparent that ceritinib is actually hitting some of those ALK mutations that crizotinib doesn't. But we also now have alectinib, X396, and multiple others all in development. And their profiles as far as which of those specific mutations they're active against is variable. Some of them are nobody's getting yet, but it's going to be very interesting. And I think just like with EGFR, it was sort of, oh, there are these EGFR mutations, and then, well, there's 19 and 20 and exon 21, and then there's everything else. And now, well, there's 20, and then there are these 18s, and 19 is different than 21, and so we keep subdividing. With ALK, we've subdivided even earlier, almost from the time it was identified. We've found that the resistance is quite variable. And I think what we'll probably be doing in the future is, based on the specific ALK translocation and mutations that are found, be able to pick our ALK drugs directly based on that. But we're not there yet.
Right, yeah, so I think it's important to remember that crizotinib kind of entered clinical trials as kind of a MET inhibitor.
Right.
That's what we thought that it was going to be, and then it quickly was found to be active in ALK disease. So you alluded to ceritinib, so-called second generation, and we have others, and these are much more potent ALK inhibitors. How have you been integrating ceritinib into your practice? Are there, I know it's now approved for after crizotinib exposure, but are there patients who should get it first?
On trials.
Okay, good answer.
This gets back to your question from before, which you talked about with EGFR. I think it's that same question of, we know with ceritinib, we know that the progression-free survival is longer for patients who have never had crizotinib versus those who have. But is that longer progression-free survival and then going on to something else, because we don't know that crizotinib works after ceritinib.
Right.
We know vice versa, but we don't know that.
Right.
So if we start with ceritinib and then it stops, what do we do next? Versus
Right.
if you start with crizotinib and it stops working, then we do. So those are some of the key questions.
Yeah, so I would actually argue that there may be a population that we should give ceritinib to, and that would be the brain mets issue, and those who have leptomeningeal disease. The ALK group is a very unique population within lung cancer, as all of us know, and their disease progression, the natural history of their disease is different. And so we see a lot of these ALK patients who have brain disease very early on in their course. And so with the second generation ALK inhibitors, they do seem to have better efficacy crossing the blood-brain barrier and having benefit in reducing tumor volume in the brain.
Well, yeah, and it may not be a PK issue. It may simply be that they're just a more potent ALK inhibitor.
Absolutely.
Right.
That's very possible, yeah.
The other issue that comes up, I guess, listening to you talk, Heather, would be how do we measure the ALK rearrangement and the mutation? Because some sites are using a FISH test, but if there are specific mutations, I guess you need to do sequencing. So that's an area that's still a bit, it's good that it's more available, but it's still a bit confused. I would think, I guess, it's going to have to become even more precise if we're going to start doing as you suggest.
Exactly.
Well, let me ask you this question, Roy. In a patient, let's say you have a 55-year-old never smoking male, and you're highly suspicious, and let's say the FISH test comes back negative, should you push for other sorts of testing to be sure?
Well,
There have been cases where they were FISH negative, subsequently found on sequencing and then responded.
the FISH test is, you just scratch your head when you look at one of those because it really depends on the purity of your sample, and there's looking for basically two probes, separating or not, and what percentage of the cells, and I forget offhand exactly what percentage you need, but there's a cutoff. So it's yeah, so yeah, I guess if that comes back negative, do you send it off for sequencing? I don't know. I think we need to do studies comparing the two, but certainly in a non-smoking male, I want to make sure that he does not have EGFR, ALK, and probably ROS1 before I treat with chemotherapy if I can.
Yeah.
But I think that's if you can.
Right.
As Tom had pointed out, pemetrexed combination, chemotherapy can work beautifully. We actually published a paper, what we did when ROS1 was discovered and talked about. We went back, we noticed we had a series of patients who had done incredibly well on pemetrexed. It had been on for like 2 years.
And guess
what?
what?
We went back and most of them had ROS1.
Yeah.
And we found 7 ROS1 patients.
That's a good point.
And I think with ALK, it's the same thing. I have a handful of patients who I know they have ALK, but they haven't had to get their crizotinib yet because they've still been stable on their pemetrexed. And so if you are suspicious, but we don't know, I think sometimes it's better just to start them on their chemo, and then you can have more time to get that testing back if it's a month or two. You don't have that urgency of this person's not on treatment.
And that's certainly true in the more symptomatic patients, and they can get benefit from pemetrexed-based therapy.
You don't want to not use the chemotherapy and hold off waiting for it, and I agree with you completely.
Okay.